relative to the TBI as a disease, the latency, which in this situation is the time from the traumatic brain injury, the time of their first, in this situation, seizure, can be as long as 17 years. So what has been going on in the brain over time that 15, 16 years later, the patient has their first seizure? There's something going on, we don't know what it is. And patients with epilepsy are significantly more likely to have strokes, which leads to the next slide. This was obviously a very large study. And if I were to ask the general population, certainly if I were to ask physicians, what is the biggest risk factor, health risk factor for having a stroke, the answer would be high blood pressure. You look at this, the risk factor for having a stroke is about the same as in brain injury as it is in hypertension. So a brain injury makes you just as likely to have a stroke as somebody with hypertension. What is it about the brain injury that causes somebody to have a stroke? Now, I will say that certainly in the immediate period after the brain injury, patients in the ICU, all sorts of things can go wrong. And this study did not break that out in terms of, well, there were strokes at X number of strokes at 4 years and Y number of strokes at 3 years. But still, this was a significant number, something about the brain injury. Next slide, please. And that was from a huge database in Taiwan. And it's the same kind of thing. You have a brain injury, you're significantly more likely to develop a stroke. And in their study, the worse the brain injury, the more likely you were to have a stroke. Something about the brain injury. Next slide, please. This is a study I've read over and over and over, and I still don't have a good grasp on it, quite frankly. This was also a Taiwanese database, and you can see lots and lots of people. They followed them for 3 years following the brain injury. And these people with the brain injury were 5 times more likely to develop malignant brain tumor than the non-injured group. And the more severe the brain injury, the more likely they were to develop the tumor. Now, I'll tell you this was from a database. And so it didn't have the type of tumor. It said malignant, and that was it. It didn't say where the location was. So we don't know that. And this has not been replicated. If you do a research study, and you find something you think is unique, you really want somebody else to do it as well, because it validates what you did and says you didn't cheat, or there wasn't a fluke. It was the real deal. We haven't seen anything like this since. But I would hope that you can see this was from 2012, that somebody is going to go back into the database, say for the past 5 years, and see if they can replicate this, because I have no explanation for this. But it's pretty significant. Next slide, please. Same group of people, and you can see that MS, incidence of MS following a traumatic brain injury. I did review a case for a lady who, interesting enough, works for a insurance daughter, had a bad brain injury. And shortly thereafter developed just florid multiple sclerosis. I mean, it was just high school student could look at the MRI and tell something was wrong. We don't know. There's lots of theories as to why people develop MS. And one theory has been that keeps building up is that there's a virus that somebody is exposed to, and then something that causes that virus to start activates the virus, it gets to start growing, sort of like the shingles. Shingles is a chickenpox virus. We just about all got the chickenpox virus. Even if you didn't have chickenpox, you probably got the virus in you. And it sits there and it doesn't bother you and you don't bother it. And then something will cause that virus to start growing and the patient will develop the shingles. And so could this brain injury cause people get this virus going and cause people to have MS. Just made me think about it. I wonder if there's been any study of incidence of shingles following a traumatic brain injury. I have to search about that. I learned something generally when I give these talks. Next slide, please. Sleep disturbance, very common in brain injury. The biggest reason I show you this slide is because you see down at the bottom, I was the lead author on this paper. That there are sleep complaints in the majority of people with traumatic brain injury. And we did a study, obviously a while back, and these were people who were getting brain injury treatment. They were in a residential treatment program. So most of them were moderate to severe brain injuries. And I'll make the numbers, I'll make the numbers easy. It was 70 people, all comers, you know. Well, initially, when you try to sign up with somebody for these research studies, what you say is, would you like to help mankind and help science? And that doesn't work. So then you say, would you like $100 for your time? And then, yes, they're interested in helping mankind. So we had 70 people, all comers, and they went to the sleep lab and had all those wires on their head and had their sleep recorded. How anybody sleeps with those wires on their head is totally beyond me. And what we found, half were normal. So they had normal sleep cycle and they were fine and dandy. But now the half that were abnormal, that had abnormal sleep, we found a lot of sleep apnea. I think most people know about sleep apnea now. It's called periodic leg movement sleep, where the patient gets down into the deep phase of sleep and their legs kick and it wakes them up. So they never get down into the deep stages of sleep. Narcolepsy, where the patient just falls asleep just like that. And that was about half of our abnormals, okay? So it's half of the half. But the other half went through normal night sleep, and yet they still had what's called post-traumatic hypersomnia. Because when you have the sleep test done, if you're really doing it right, you stay in the lab the next day and you take 4, maybe 5 naps throughout the day. And we wait till you get to it, and you're still hooked up, and we wait till you get down to a certain stage of sleep, and then we wake you up. And we do this 5 times during the day. And if you fall asleep on average of less than 5 minutes, then you are felt to be clinically sleepy. Now, some people will say, I can fall asleep just like that, but not 5 times during the day. That's a lot. And so roughly 25% of the people that we studied had abnormal, they were clinically sleepy, and yet we had no explanation as to why. And obviously, if you're sleepy, you're going to have cognitive issues. Also, we would have the patients fill out a self-assessment. The one we used was the Epworth, and it's like I fall asleep at stoplights, you get 2 points. I fall asleep when my wife is talking to me, you get 3 points. And I fall asleep, and if it was a certain number, that meant you may have a sleep problem. You ought to go see the doctor. We had patients who had terrible MSLTs. We had one who was her average for 5 naps was 1 minute. So she was asleep, when they turn out the lights and you still have that after image in your eyes. She was asleep before that after image was gone. And she had no idea at all that she had any kind of sleep problem. And she drives. She's in Pasadena, Texas. If you don't live near Pasadena, Texas, you're probably safe. Next slide. Unfortunately, brain injuries are associated with increased mortality. We'll talk about that more. But this was a large study, and what you can see, the interesting thing, the take-home message to me was that after the first year, first year after brain injury, all sorts of medical issues, and so you can understand why there would be increased mortality in the more severe brain injuries during that first year. But if you subtract out the first year, the mortality incidence, it didn't make any difference if your brain injury was mild, if it was moderate, or if it was severe. You were all clumped together. So the severity after the first year was not a factor in who had the brain injury. Who died. And The other part of the study is it also looked at mild TBIs, concussions, if you will. We'll talk more about concussions, but the death rate from mild TBIs was twice that of control. Something about the brain injury. And we'll talk about the cause, I think, in the next slide. Nope, maybe a slide after that. Another study, again, same kind of thing. Neurodegenerative disease, and we'll talk about neurodegenerative disease, but you can see the comorbidities, as we say, that are associated with increased mortality after TBI. And these comorbidities, these other medical issues, certainly are going to impact who is going to die eventually from their brain injury. And the biggest ones are cardiovascular issues, neurological issues, and respiratory issues. Next slide, please. And here it is, the cause of death. Seizures is a big one. And why is this important? Because if you have a loved one, or you have a friend who's had a brain injury and they have a history of seizures, and they say, man, I haven't had a seizure in 6 months, I'm going to stop my medication. No, you need to be on the medicine. You need to talk to your doctor about that, because uncontrolled seizures increase cause of death. Septicemia is overwhelming infection. Aspiration pneumonia is hamburger goes down the wrong pipe, because people with brain injuries very often have swallowing issues, and your hamburger it's not a good place to sit in your lungs, because that's where things grow. And so a lot of infections, respiratory issues as the causes of death. Next slide, please. Neuroendocrine dysfunction. I got involved in this. I think we published our first paper about 22 years ago, as a matter of fact. Hypopituitarism refers to a problem with the pituitary gland. Your pituitary gland is the size of a pea, and it is dead center within your brain. You can see if my fingers could touch, which wouldn't be that hard, I don't have much in there, that it would hit the pituitary gland. The size of the pea is the master gland. It turns on and off all sorts of hormones. And what we found was, in roughly 30% of individuals with a moderate to severe brain injury, they had some sort of pituitary dysfunction. We'll talk about more detail in just a bit. And it doesn't necessarily occur at the time of the injury. A large number of people who are normal at 3 months will eventually develop pituitary dysfunction a year later. And you say, well, it's only 5%. But in medicine, 5% is important. That's a lot of patients, and it's something that needs to be addressed. The theory is that you have extra cells, and these cells die off. So you have extra pituitary cells, and so some are impacted by the brain injury, but as time goes on, they die off, and then you don't have anything left. So that's the theory. Next slide. The bad boy in all this is growth hormone. At this point in our lives, growth hormone has nothing to do with being tall, but we all need growth hormone till the day we die. And we found we and others now have found that roughly 20-25% of individuals with moderate to severe TBIs will have growth hormone deficiency, and recent publications have indicated the same number in people who've had mild TBIs, concussions. These are people who are symptomatic from their concussion. If you've had a concussion, 30 years ago, and you're fine and dandy, it's unlikely that you have this. But for people who remain symptomatic from their concussion, it could be due to hypopit. And these are the symptoms that people will have if they have growth hormone deficiency. The nice thing, if you will, about the diagnosis is it's something we can treat. A lot of stuff that we do in brain injury, we can't treat. A lot of stuff in neurology, we can't treat. But this is something we can treat and make the patient significantly better. So this is something that those of us in the brain injury world look for, because again, this is something we can treat, and we can really change lives if we do replacement. Next slide, please. Thyroid dysfunction, 5%, people with moderate to severe TBI. far more common in females. About 3% of you females out there in the audience will have thyroid problems. It's a fraction of that in males, but that's due to your thyroid itself not functioning okay. One of the things that the pituitary gland does is it turns on and off. It regulates a lot of hormones. It regulates growth hormone. It regulates the male and female hormones, talk about in a sec, and it regulates your thyroid. So the problem is in brain injuries, not from thyroid problems, thyroid itself, it's the regulation of the thyroid coming from the pituitary gland. And these are the symptoms of somebody who is hypothyroid. Thyroid level is low. I have a friend who had a thyroid cancer, and they have to ablate it, wipe it out, and then you're trying to regulate the thyroid level, because very often they don't get it at all, and there's a little piece that's active, and it's something very, very hard. And she said she always knew when her thyroid level was low because she felt stupid. And she was kind of like, didn't like feeling stupid. And it's easy to test for. You go to the doctor for your annual checkup. You say, gee, I feel tired. You're probably going to check your thyroid. And the neat thing is, if you are hypothyroid, the replacement is, the cost is unbelievably cheap. So it's something we look for in our. Next slide, please. And then gonadal hormone dysfunction, male and female hormones. Lots of complaints about sexual dysfunction after a brain injury. Now, I will tell you, in females, I don't know about males, but in females, acutely after the injury, your gonadal hormones just shut down. And perhaps, and not just brain injury, any major trauma to your body, the women will stop menstruating. And perhaps this is Mother Nature's way of saying, you're not ready, you're not capable of carrying a baby because you've had this injury. But eventually, majority, they start menstruating and their hormonal cycle is normal. But there are some that don't. And especially what we see in the males are these complaints you see here. Libido, they've lost their muscle mass, they have decreased strength. And there is some correlation between a low testosterone and cognitive function, which all goes to show that men may really think with their penises. And then there's, in pediatric situation, it leads to what's called precocious puberty. So let's ignore that one. Okay. And this is basically kids go into puberty early. Okay. And as a result, they will have short stature because the end plates of the bone will fuse, and that will prevent the bone from growing further. So they're generally of short stature. Now, these are young 11-year-olds, 12-year-olds, 10-year-olds, females who are now developing their secondary sexual characteristics. So they're developing large breasts, and they're at risk for sexual abuse. And because of this, because of the early puberty, they're at greater risk for breast cancer in the future. Males, we know that they're greater incidence of aggressiveness, and we know that there's a large incidence of attention deficit disorder following a brain injury. When I first started in this field of brain injury in the mid-90s, brain injury was an orphan disease. Nobody knew anything about it. Something good usually comes out of something bad, and the good that has come out from the wars and the NFL is people now understand about brain injury. In fact, Friday is National Concussion Day. I think this is National Concussion Week. I think Friday is National Concussion Day. Doesn't mean go out there and bang your head against something. But now people are aware of it. But pediatric TBI, that's the orphan of the orphan. And good luck finding a rehab doc, a neurologist that specializes in pediatric brain injury. There are very, very few. And kids with brain injuries just grow up to be adults with brain injury. They are the lost ones in our field. Next slide, please. And these are the problems that they have. and it's not insignificant. And nobody, they're in school and they get put in special education, and special education teachers are just overwhelmed, and they're dealing with kids with all sorts of issues. And the kids get lost, and it becomes a real problem. Again, kids with brain injuries just become adults with brain. Next slide, please. All right, I despised biochemistry. Absolutely despised it. And now I'm knee deep in biochemistry. We're going to talk about the amino acids. You are made up of amino acids. It's the building blocks of our body. This is what makes up the protein. When you went to lunch or you had a Big Mac, you had amino acids. This is what we're made of. And you can see what amino acids do in the body. And for those in my world, what is really important is that these are the precursors to the neurotransmitters, the chemicals that make our brain work. And that's what the amino acids do. That's the big thing. Next slide, please. So this is a while back. I need to fix this slide. See, this was in the year 20,000. So I think that's probably wrong. Anyhow, this was an Italian study. And if you've ever been in Italy, you'll understand why brain injury research is prominent in Italy, because they have cars going this way and cars going the other way, and then motorcycles going both ways in between the cars going this way and that way, and something that used to be a donkey cart path. So brain injuries are a significant issue in Italy, and a lot of very good research comes out of it. They looked at people with 1.5 months after the brain injury, and they found a lot of abnormalities. Now you see NEAA stands for non-essential amino acids. You have 10 of those in your body. And what your body can do, it can take this carbon chain and this hydrogen and this oxygen, and it can make a non-essential amino acid. The blocks are there, and your body can put those blocks together. Essential amino acids, your body can't do that. You got to eat it. The only way you get the essential amino acids is if you eat them. Okay, so you have to absorb them. And of the essential amino acids, is something that's called the branched chain amino acids. These are the big boys. These are the ones that are really, really important because they make up a significant part of our muscle mass. So anyhow, a month and a half after, they said, gee, it's all screwed up. But they just had a brain injury. And maybe on LV. So they did it again 3.5 months. And there were still lots of abnormalities, but could it be that they just don't have adequate nutrition? They've got a feeding tube, either in their stomach or down their nose. So maybe that's all that is. So can I have the next slide, please? So we did a study, and it was 6 males, because males are the guys that usually do the stupid things, although women are catching up. And the guys that went through brain injuries. At the time, we didn't have this epidemic of obesity. And so people were eating, this was a residential treatment program in Galveston. People were eating communal family style. So they can eat, if you will, as much as they wanted within reason. But, we controlled the diet. So it was a healthy diet. And we had 8 people, guys, who were the healthy controls. And we measured their baseline amino acids. And then we gave them a supplement, sort of a milkshake of essential amino acids. And then we measured them. Okay? So baseline, take some amino acids, and measure the level again. Okay. Next slide, please. And bottom line to this slide is that we found a lot of abnormalities still. And that even after supplementing the essential amino acids, the concentrations did not change significantly in people with the brain injuries. Controls did, but the brain injuries didn't. And then the bad boy in this was valine. And then we were going to do a study and looking at valine. But then once again we got hit by it was the same. No, it was a different hurricane. You wonder why in the world I live here. Well, I have a house on the water with a pool and a boat. That's why I live here. It's really cool. And so we just got nowhere. And the researcher, Elizabeth Borsheim, couldn't decide whether or not she wanted to move back to Norway or stay in Galveston. And so she moved to Arkansas. Nice place. I've been there. My son trained there, but never understood that. So it was this sort of was in limbo. Can I have the next slide, please? And just didn't know where to go now, because we were looking at people in the post-acute, first 3-4 months. And we had a long-term living program where people could not go back home, or the family couldn't take care of them. And so it was a congregate living environment. I said, I know, because I'm the physician, I'm treating them. I'm seeing them dwindle over time. And maybe this is what's going on. And so what we did was we had controls, and you can see the blue and the light green, or whatever, blue green. That was group A. Those were the healthy controls. I was a healthy control. And then the green and the orangish color, those were the people with the brain injuries. And we all had our blood. We fasted. We had our blood drawn. We all ate breakfast. It was the same breakfast, it was an average kind, eggs, bacon kind of breakfast. And then we had our blood drawn again. And what you can see from this slide is that in the control group, again, the blue and the greenish, that we started out at a higher level of essential of these branched chain amino acids, the important ones. And after we ate, it went up. But in the brain injury group, it went up, but they never caught up. They never went to the level that they should have. So what is it about the brain injury? Where did the bacon go? Where did the eggs go? Because they certainly weren't absorbing them into their system. Next one. And there's another way of looking at it. But here's the controls, the healthy people. And the red is the essential amino acids, and the bolder red, those are the really important ones. And you can see they went up. They went up. That's what's supposed to happen. So look at the people with the brain injury. Only phenylalanine. So where did these amino acids? Next slide, please. And now I work for the company based out of Bakersfield, the Center for Neuroskills. At the time, I was running the program in Galveston. And although the real researchers in our research group said, they ran the statistics, and they said, this is good, this is enough, we can get this published. I said, no one's going to believe a study on 10 people with brain injuries. They'll just won't believe it. So I called Mark Ashley, for whom I'm going to work, and Mark runs Center for Neuroskills based out of Bakersfield. And we have programs in California and Texas. And I said, Mark, how'd you like to win a Nobel Prize with them? You replicate the study and see what happens. And they found the exact same thing. So it wasn't us. It wasn't something inherent in Galveston or inherent in the food that we were giving these folks. It was essentially the same in people spread across thousands of years. Next slide, please. And I'll tell you where this is headed. We scratched our heads. Where's the bacon go? And one thought was, well, maybe it all gets sequestered, stuck in the liver, which is sort of a filter. And then we said, no, that's it. Somebody, not me, I admit, said, well, maybe it's the problem with the microbiome. Maybe their gut bacteria are abnormal, because you have roughly 3 pounds of bacteria in and on you. And we, it's symbiotic, we work with the bacteria, they're good for us, we're good for them. And you have bacteria in your gut. And the bacteria in your gut can say, okay, eggs, you come on into the system and, welcome to the club. The bacteria can say, nope, we're not letting you in at all. You're going straight out in the poop. Or they can say, this is good stuff. I'm going to take the eggs, me, Mr. Bacteria, and I am going to grow and flourish. And so we looked at the microbiome in the individuals with traumatic brain injuries, and we found they were significantly different than the controls. Once again, I said, nobody's going to believe this if it's just us in Galveston. So we replicated it in Bakersfield, thousands of miles away. And they have a similar microbiome to the people with brain injuries in Galveston. Now, why is this unique? My children, my two sons, probably have a very similar microbiome because they grew up in the same house, they have parents, and they live 3-4 miles from each other. So they're exposed to the same bacteria, and they probably have a very similar microbiome. But the people with brain injuries in Galveston theoretically should not have the same microbiome, give or take, as people in Bakersfield. So what is it about the brain injury that causes the microbiome to change in a significant way that causes the patient to essentially starve? That's what we're working on now. Of course, you'd say, well, just fix the microbiome. It's a lot more complex than that. You can't just go to the grocery store and drugstore. Well, there's tons of probiotics and prebiotics. It's just not that simple. But that's what we're working on right now. We've published some papers, and hopefully we'll have an answer on that in a few years. This takes a lot of time. All right, I'm going to move on to some of the other illnesses that may occur. Psychiatric disease is very common in the United States, and you can see from brain injury, it can be quite common. There's a high rate of suicide ideation, in other words, thinking about suicide attempts, and completed suicides. And this was the one at the bottom. The entire population of Denmark, everybody in Denmark, was studied over this almost 25 years, 35 years. And they found that if you had a brain injury, you were twice as likely to have a risk of suicide than if you didn't have a brain injury. So what is it about the brain injury that causes you to consider suicide? And this was all types of brain injury. It wasn't just the severe brain injury, the mild brain injuries as well. As you know, you take nothing home except this. A concussion is just a nice way of saying a brain injury. It's the same. There's no difference at all. It just sounds nicer. Next slide, please. I find this slide very interesting in that I can understand developing a personality disorder after a brain injury because your life's not the same. Physically, you may not be the same. Cognitively, you might not be. I can understand a personality disorder. But studying these 60 folks over 30 years, they found half developed a major mental disorder after their brain injury. We're not talking about being a little depressed or a little anxious. We're talking about psychotic, schizophrenia. We're talking about major depressive disorder. They can't get out of the bed. We are talking about bipolar disease. So what is it about the brain injury that cause somebody to have these problems well after their PDI? Next slide, please. And this is from the Institute of Health, now called Institute of Medicine, now called Institute of Medicine and something. They changed the name a little bit. And if a congressperson wants to know what's the incidence of gallbladder disease in left-handed blonde females, if they can rustle up the money, then the Institute of Medicine will get together a panel and they will address the issue. They won't do the basic research. They won't do clinical studies, but they'll review the literature and come up with their opinion. And that opinion may be a book. It may be a couple pages. It can be anywhere in between. And in 2009, they put out a book called Gulf War and Health, which you can download the whole thing if you wish, and you have enough paper in your copier. I find it interesting. The title was Gulf War and Health, although it was all about brain injury. And if you remember early on in the days of the wars, the military did not want to talk about brain injury, although ultimately they said it is the injury that we see. So I just found it a little interesting that they decided not to say go for it. So relative to this, the previous slide, when they talked about the incidence of mental psychosis and mental disease, they said that even if the brain injury is severe, the psychosis does not appear that first year. It shows up 2 to 3 years later. So what has been going on in the brain injury that causes somebody to become psychotic 2 to 3 years later? We don't know. And I've had several patients with exactly that. One company that put that tunneled under highways for cabling. I had maybe a half a dozen employees, and he was able to go back to work. He just went bananas. It was microwaves coming from Denny's restaurant, and it's really, really cool. And he had been functioning fine. What's it about the brain injury? Next slide, please. And in Alzheimer's type dementia, individuals who've had a moderate to severe brain injury, and now we're trying to slide in the middle a bit. We think mild can predispose somebody to developing something akin to Alzheimer's disease, or be a contributing factor to somebody developing Alzheimer's. We know that people with hypertension, we know that people who drink a lot, people who are sedentary, these are all risk factors for the development of Alzheimer's disease. There's a lot outside of it as well. But brain injury is also a risk factor for developing Alzheimer's disease, or a cognitive issue that it doesn't fall in the definition of Alzheimer's, although it certainly will appear that way to the general public. And obviously, the worse the brain injury, the more likely the risk. Next slide, please. This was a study I first read about when I was traveling and doing a talk somewhere, and it was in the newspaper, and it showed that. I'll go to the bottom portion of the slide. These were individuals with mild TBIs. These weren't, for the most part, not war-related TBIs. These were mostly civilian kind of TBIs. They had twice the risk of developing dementia. So something about the brain injury, even mild. Next slide, please. And even if you don't have cognitive issues right after the brain injury, you still run that same risk of developing cognitive issues later on. Next slide, please. An increased incidence, risk of developing Parkinson's disease, and then chronic traumatic encephalopathy. When I first started doing these talks, everybody just sort of rolled their eyes, never heard of it. Now I think everybody knows about it. We used to call it dementia pugilistica because it's something we see in fighters. But it would be the slow progression of all these cognitive issues associated with psychiatric disease. So it's not just Alzheimer's disease. Let's go to the next slide, please. And we know, again, this goes to that early slide about why people got worse over time. Well, this was a study where we looked at the white matter. The white matter is that part of the brain. You have the gray matter, which is the thinking part of your brain, and the white matter, which is the messenger carrier within the brain. And we're now able to look at the white matter. And what they found in the study was 3 years post-injury, the white matter was still changing. Now, maybe some of it was changing for the good, but it wasn't changing the way to get back to the way it was before. And so perhaps this is part of the reason why people with brain injuries may get worse, is because their white matter is still negating. Next slide, please. And this is something that just came out like a month ago. And I'll try to make this compact. But this was 152 people, young individuals, averaging 23 years, all less than 30, whose families donated their brains to this brain bank in Boston. Half of them, well, 63, were diagnosed with chronic traumatic encephalopathy, which is a pathologic diagnosis, only can be made on autopsy. Okay? But you can see the breakdown of the individuals who were involved. There were 11 professional football players, a couple of hockey players, one professional rugby player and a professional wrestler, which I think would be really a hard end to break. And the donated brains are 11 females. One played collegiate soccer, the one that was abnormal. Again, all these people were athletes. They all just high school, mostly high school, then college, and I got some professional. Okay, so 63 out of the 152 have pathologic changes in their brain. Next slide, please. Those who play football, the longer your career, more likely you will develop this. Here are the symptoms. Interestingly, if you had CTE on your autopsy or you didn't have CTE on your autopsy, you still had abnormal mood, you had impulsiveness, your functioning was wrong. Remember, these were people that all died. And the most common cause of death was suicide, accidental overdose, which probably means there are a lot of purposeful overdoses or drug use and trauma. So these were all individuals who died young, with the biggest causes being cognitive, emotional kinds of things. 60% of the people with repetitive head injuries did not have pathologic changes in their brain, but they were still symptomatic. So maybe it's coming. Maybe it's starting to happen. It just didn't show on the autopsy. Next slide, please. So what are we supposed to do? So this is, I'm not going to read this, but it's got to be obvious. The biggest is let's try to limit the amount of head drills that the kids will have. Try to create some way of monitoring how often the child hits their head, because it's not so much the actual concussion. It's something that's called subcussive hits. Ring your bell for a second, not enough to knock you out, but enough make you just dazed for a second or two. And it looks like it's the number of subcussive hits, which is the real bad boy when it comes to who develops this traumatic encephalopathy syndrome. And then when they die and they do the autopsy, they say they have CTE. This is something we need to address as adults with kids. Now, I'm not saying don't do anything risk-taking. I have certainly done my risk-taking in my life. But we need to limit, I wear a helmet when I'm skiing. We try to limit those possibilities. Next slide. So what could possibly be going wrong? What is happening? Well, there's something that's called the blood-brain barrier, which keeps the bad stuff out. Well, perhaps after the brain injury, the bad stuff can leak into the brain. Liberation of free oxygen radicals, which is, antioxidants was the big thing, and to eat more blueberries, I have no idea. Loss of brain reserve capacity. We talked about that relative to the pituitary gland. You have these extra cells, and they die off, and there's just nothing left. Amyloid plaque, which is like scar tissue, and there's evidence there's a chronic inflammatory process. You can inflammatory markers within the brain still evident. Decreased blood flow. Nutritional deficits, and then apoptosis, which is what's called cellular suicide. All our cells of our body are on a timer. Is there something about the brain injury that resets the timer and causes the cells to die and then the patient to have their whatever their issues are? And there's evidence that this may be a factor as well. So there's lots of possibilities. It's not going to be one thing. It's going to be multiple things. So we talk about finding the cure. We really talk about finding the cures. Next slide. Okay, so summing it up here. Again, this is from the Institute of Medicine, and they did this analysis, and they'd say, well, they'd categorize things in a fashion like maybe related. The TBI probably is related. TBI is causative. So this is limited suggestive evidence. Yeah, maybe the TBI can cause these kinds of problems. Okay. Next slide. Positive association. Okay, it's probably not due to chance and not bias picking your population. And you can see the connection between the type of brain injury and the type of medical problem that occurs. And I will tell you that the people that they get on these panels, the Institute of Medicine gets on the panels, they're the smartest people in the room. We have no Bible in medicine. Every time I've done some book chapters, and by the time the book chapter comes out, it's already out of date. It takes forever for that to happen. So we have no Bible. We have no the source. But when the folks with the Institute of Medicine put out things like this, you listen, because these are the smartest people in the room, and this is what they're saying. Next slide, please. And then causal relationship. That's the fact job. Penetrating TBI provokes seizures. Mild severe TBI provokes seizures. Penetrating TBI premature death. It's like there's no question about it. Next slide, please. So, annually in the United States, there's over 100,000 individuals who become disabled due to the brain injury. Become disabled. That means 5 million Americans, give or take, are disabled due to their brain injury. And I think as a result of their trauma, they have brain injury disease. Next slide. And I think brain injury disease should be taught and reimbursed and paid for just like other chronic diseases, like I said earlier, just like diabetes, just like heart disease. Because only then will we treat the patient with the disease as opposed to the disease and the patient. And only then are they going to get the medical surveillance and the treatment and the support that they need and deserve. And only then will brain injury research get the funding it deserves and requires. And only then will we really be able to talk about a cure. Next slide, please. So I want to thank all my staff. And next slide. Oh, wrong way. Okay, one more slide. There we go. So that's it. I want to thank you very much. Boy, we finished right on time. So, any questions?
So we did not have any questions in the chat yet. If anybody does have any questions, they can quickly type them in. In the meantime, I'll just ask if you could follow the link that I put in the chat to fill out an evaluation. We would appreciate that. I want to thank Dr. Masel for your presentation and Maureen for his introduction and slide movement.
And Tess, if anybody has any questions later on, just I can give you my email address, or they can just email you and you can email me, whatever works.
Perfect. Yeah, if you could, you're very welcome to put your email in the chat if you want, or again, they can email me and I can forward them on. Just a couple of thank yous. Very informative presentation. I'm going to go ahead and stop the recording.